Hi everyone, it's your friend Doris, TheCoder, back with another video, and in today's video we are going to break down some of the terminology which quite candidly when it came out in 2022 had me very frustrated um, on congenital catheterization. So the good part is now with congenital we've got codes that are more closely reflect the work associated with doing a congenital catheterization. And work that's a little more valuable in the sense of what happens in the pediatric or congenital space. But we also have terminology that we've probably seen in our report and didn't pay much attention to, that now we must pay attention to. So this, if you have your 2022 CPT book, we're going to break down this statement on the right side of page 775. It's the first paragraph that starts for reporting purposes, and it reads, for reporting purposes, when the morphologic left ventricle or left atrium is in a subpulmonic position due to congenital heart disease, catheter placement in either of these structures is considered part of a right heart catheterization and does not constitute a left heart catheterization. So it goes beyond us seeing those initials LV, RV, RA, MRA, MLA, right? And saying right or left, we actually have to kind of make a bit of a decision to understand what's going on here. So let's start with morphology. And I got stuck on this because I'm thinking, what are they saying? A coder's level knowledge, morph meaning shape. What do they mean? Like shape, what are we saying? So looking at this gross anatomy image is actually very helpful to understand what's happening when they say the heart. So my pointer here, there we go. Right. So you'll notice that the right side of the heart has these, and at this point they look a little weird, but they're almost like little bands or tendons, that's what it really kind of looks like, right? We have this kind of structure, and then the left side of the heart is a lot thicker. I like to think about the heart like a house, right? Actually quite interesting because it has plumbing, it has electrical, it has walls, it has doors, it has halls, right? And rooms. The rooms are the heart, are our atria and our ventricles, right? The chambers, the upper chamber, the atria, the lower chambers, the ventricles. The halls of the heart, I think about them like the halls or the tunnels, are hallways, or like I'll say the blood vessels, like the aorta and the pulmonary veins and the pulmonary artery, right? Those are the halls of the heart. We have doors in our house as well. Some internal doors, some external doors. So we have doors that are valves, right? Our mitral valve, our tricuspid valve, our pulmonary valve, our aortic valve. Those valves we've got to go through those doors to get to the halls. And we also have walls. And walls is what we're going to kind of talk about today. So what you're looking at, this thick middle area here, is a septum. And this septum actually goes all the way from between the ventricles all the way up to between the atrium as well. It's not really beautifully depicted here, but trust me, that's a fact. So you'll see the interventricular septum as they labeled here. You might also see some drawings or some images that show the interatrial septum. That is the wall between the upper chambers, the atria, and the walls that's in between the ventricles. So now that you kind of better understand that anatomy, pardon me, I'm trying to adjust my lighting here. Not a tech person. Didn't really just make that better. Okay. Right. So when we look at how the heart works, we can see very clearly a difference between the shape on the left and the shape on the right. This is where morphology is coming in. So the right ventricle, there is a reason the heart is structured the way it is, the way it's built a certain way. When we think about the roles of the right ventricle compared to the roles of the left ventricle, the right ventricle has the responsibility to pump blood to the pulmonary artery. Like that's what it does. So normally the right ventricle just has to pump to this structure right here, right? The pulmonary artery, that's pretty much in close proximity as far as the distance the blood from the right ventricle has to travel to go where it's going. In this case, the lungs via the pulmonary artery. The left ventricle, however, has a greater responsibility in that it has to pump blood to the aorta, and you think, well, wait a second, the aorta is just as close to the left ventricle as the right ventricle is to the pulmonary artery. But the force that it has to contract or push, remember, we're not just trying to get blood to the aorta, we're trying to fill the aorta and at a rate that it perfuses and kind of spits that blood, that oxygenated blood, to every end organ. So that's up and down, right? So the aorta has to perfuse so forcefully that we can perfuse you all the way down to your toes and all the way up to the brain. That makes sense when we look at the physiology or the shape of the left ventricle. It is more muscular. It is bulkier, right? Because it's got to push the heart, and it also has to push against a higher pressure system. There is higher pressure in the arterial system than in the venous system, right? Because, well, again, it's how far we're kind of traveling, and we're dealing with oxygenated blood versus deoxygenated blood. I like to think about it in a non-clinical person's mind, to think I move a lot faster, I'm much more energized when I'm oxygenated, right? When I'm fed, right? I'm less energized, I move a little slower if I'm deoxygenated or I'm not fed. So think about it that way when you think about the left ventricle compared to the right ventricle, or the pulmonary arteries compared to the aorta. So when we see morphologic, there are some disorders, and this is a normal heart. So the left ventricle should be muscular and bulky because it's prepared to push up against that higher pressure system. And the right ventricle doesn't need as much muscle bulk. It has that shared middle wall, but it doesn't need as much muscle bulk to push that blood into the pulmonary artery, which isn't kind of depicted on this particular slide. So in some conditions in the congenital space, the builder got it wrong, right? If we thought about the left ventricle as the master bedroom, they put the master bedroom on the wrong side of the house, right? It's connected to the wrong thing. I didn't want to be connected to the side with the kids. I wanted to be on the other side by myself, right? So when we look at some of the conditions, for example, TGA, and this is a picture of that. I wish I could make that bigger. And let's do this. I'm going to zoom this in. Hopefully that made it a little bigger for you, right? So this condition, this is actually TGA, right? I'm going to go to CCTGA because CCTGA probably better depicts this, what I'm trying to tell you here. Give me a moment. So this is a picture of CCTGA and DTGA, right? So congenitally corrected TGA. So in a condition like this, now you've got to, again, go back to normal anatomy. So in normal anatomy, the right ventricle is built like the right ventricle. It's not so muscular, and it connects to the pulmonary artery. In a condition like CCTGA, the builder got the plans wrong. So they put the left ventricle on the wrong side of the house. So notice how the muscular side, the muscular chamber is actually on the right side. In a case like this, when this happens in a condition like CCTGA, the provider will document in the Cath report that the morphologic left ventricle is in a subpulmonic position. That means the master bedroom is put on the wrong side of the house. And then the right ventricle then, right, they switch places. The right ventricle is built like a right ventricle, but they put it in the wrong location on the plans, right? So the right ventricle is pumping to the aorta. The left ventricle is pumping to the pulmonary artery. The implications of that is the right ventricle will eventually fail, right? Left ventricle is not so bad, but the right ventricle is pumping up against a higher pressure system, so it has to work harder. So what eventually happens is the right ventricle will fail, is what my physicians tell me there. So when we are coding, we'll go back to the guidelines. Right side of 775 of your 2022 CPT, if you've got the professional edition, it says for reporting purposes, right? So this is when we're coding. We've got to almost ignore the abbreviations when we're doing sides of the heart and pay more attention to the pathology that's in our report because it'll change it. You might see the provider say that the morphologic left ventricle, this guy here, is in a under the pulmonary artery, subpulmonic position. That means they're going to catheter, and they don't have to do necessarily femorally because sometimes patients have septal defects and they don't have to. That's one of the reasons I think they possibly took the access out of the coding for 2022. It's not in the code descriptor, but there remains a section in the non-congenital section guidelines that I don't have clarification on from the AMA. We're doing our best with that for right now, but that's why they took the access out of, because when a patient has congenital heart disease, they often have a lot of issues going on. So they may very well, they access arterially and go through a septal defect and do their heart cath. So don't look exclusively to a venous access, but what you might see is something like a venous stick. They go to the right atria, and you'll see venous stick, superior vena cava, maybe inferior, whatever, depending on what the situation is. Right atria, left ventricle, pulmonary artery, and you think, well, wait a second. In normal anatomy, they'd have to go right atria, left ventricle, pulmonary artery. They don't kind of do that from a catheter perspective, not only because it's very technically difficult, but it's just not what they do. So that will be a clue for you. If we go from right atria to left ventricle, you may have missed the term subpulmonic, or you may have missed the term morphologic. They only use those terms in aberrant anatomy. So if you see morphologic, subpulmonic, etc., they're telling you something's built wrong, something's out of place. So go back to your summary, go back to your history, and see what the patient's pathology is. So when they say for reporting purposes, the left atria or left ventricle when it's in a subpulmonic position, it's part of a right heart cath and not a left. That's because the left ventricle is now acting like a right ventricle, right? Because it is subpulmonic and pushing to the pulmonary artery. On the contrary, you might see in CCTJA, they say the right ventricle is the systemic ventricle, or the systemic right ventricle. Well, what are they saying there? They're saying, again, the builder got the plans wrong and they propped the room. So now the right ventricle, systemic means connected to the aorta, or subaortic, or under the aortic valve. This is the chamber responsible for perfusing the entire body. So when they say the systemic ventricle is a right ventricle, right, they're saying one of two things. They may say it's a subaortic right ventricle, or the systemic ventricle could be in the right place and the aorta is refashioned to connect to the right ventricle. You may see that in single ventricle disease, right? So if a patient has something like hypoplastic left heart syndrome, so I'll show you what this image looks like. And I had one that I liked. I'll use Adam. Adam's a good one. Why did they come up so small? Let me make this larger for you. Right. So this is my left ventricle. In normal anatomy, my left ventricle is this big, right? But now this left ventricle in hypoplastic left heart syndrome or some of those disorders, it's a lot smaller. This is a patient who actually physically has two ventricles, but really they just have one ventricle because I can do nothing with this. So where you might also see the systemic ventricle, the right ventricle is a systemic ventricle or subaortic. If it's not a condition like CCTGA, where it's actually positioned subaortic, it may be a situation where a patient has single ventricle and they've now made the right ventricle the systemic ventricle by anastomosing the aorta to the right ventricle, right? Because that can pump to the aorta, because if I got that little ventricle on the left, it can't do anything. Now you would probably ask, well, if the right ventricle is now the systemic ventricle and I attach the aorta to the right ventricle, how is blood getting to the lungs? That's where you start to see Glenn's or Fontaine's, or different surgical procedures that they do to directly anastomose the vena cava to the pulmonary artery. So blood doesn't have to go into the heart to get to the lungs. They establish direct routes there. So this is going to be your Cath tip. Be aware when you're coding that term subaortic, morphologic, subpulmonic, that's what they're talking about. Go back to your anatomy, see why the terms in there. Usually the providers, 8 times out of 10, you'll see the catheterization in the order that they do it. Like they'll take the pressures as they go. They're taking saturations, pressures, or doing angiography. Like they do it on path. They do it as they go. So if you look and you think, well, wait a second, this provider is bouncing all over the place, you could have either aberrant or anatomy or surgically altered anatomy. That's why your guidelines now are telling you that the shunts also count as abnormal connections in addition to the disease. I think it also affirms the American College of Cardiology's point that just because a patient's had a Fontan or Sano or DKS or a baffle or a mustard, some of those procedures does not mean they don't have congenital heart disease anymore, because the ACC affirms that the only way to correct congenital heart disease, some of the major cyanotic ones, is the transplant. So everything we do with that, when you see the term palliation, it's I don't have a bunch of organs sitting by. This is going to hold the patient over in the interim, right? But they still have congenital heart disease until they get that transplant. So I'm your friend Doris, TheCoder. I hope now you can go back to your CPT guidelines and be less confused, because this was so frustrating to me. I mulled and mulled and mulled, and I'm so grateful for the support of my physicians, because they could break this down. They drew a picture for me, and I'm like, oh, is that what it's saying? That's why they're saying shaped. That's why it doesn't matter. So hopefully this video has helped you understand the term morphologic, subpulmonic, and subaortic. And when you are coding now, you navigate through to your reports. You code right heart cath properly, left heart cath properly, or combined if it shows up. So until the next video, I'm your friend Doris, TheCoder. Like it if you do, share it, subscribe so you know when I post. And until the next one, I will see you then.